Hey everyone, and welcome back to Student Nurses Station. I'm Nurse Don.
And I'm Nurse Jill.
Don't forget to like and share and subscribe so other nursing students can find us too. And hey, if you're looking for some extra study help, we've got a link in the description for free downloadable nursing books.
Absolutely. We know you guys are busy, so feel free to listen while you're driving or doing laundry or whatever else you've got going on.
All right, so today we're jumping back into our head-to-toe assessment series with part 2. Last time we talked all about how to really observe your patient, from how they're breathing to their skin color, and what those observations might tell you about their overall health.
Exactly. Those visual cues are like the first chapter in your patient's story. And today we're going to dig deeper into some specific assessments, starting with the ears.
Okay, ears. Now I know what you're thinking. Checking someone's ears isn't exactly rocket science. But here's the thing. Assessing hearing from the moment you meet a patient can be super insightful.
It's true. Think about it. If your patient can't hear you clearly, it can impact everything from their ability to understand your instructions to even their overall safety.
Right. It's not just about whether they can hear, but how well they can hear. So how do we even approach asking about their hearing? What are some key questions?
We want to start by asking about any recent changes. Have they noticed any sounds being muffled? Do they have to turn up the TV louder than usual?
And I imagine you'd also ask if certain sounds are harder to hear than others.
Absolutely. You're looking for patterns. Maybe they can hear low-pitched sounds just fine, but struggle with high frequencies. That can give you clues about the potential cause of the hearing loss.
That makes sense. And what about other symptoms? I know sometimes hearing problems can come with other things going on.
You're exactly right. You'll want to ask about things like drainage from the ear, any pain ringing in the ears, which we call tinnitus, and even dizziness or vertigo.
Here you go. That's the feeling that the room is spinning, right? That can't be fun.
Not at all. Vertigo can be really debilitating, so it's important to distinguish it from just feeling lightheaded. With vertigo, the patient feels a sense of movement even though they're standing still.
Okay, so we've talked about what's going on right now with their ears. What about their history?
Past ear infections, trauma surgeries, all of that can impact their current hearing. And don't forget family history.
Of course. Hearing loss can run in families.
Exactly. And then we can't forget about lifestyle. Think about the things that can put a strain on our hearing: loud noises, frequent swimming, even those little earbuds we all love.
Oh yeah, I'm definitely guilty of cranking up the volume on my headphones sometimes.
We've all been there. But as nurses, we need to ask about these habits. Does their job involve loud noises? Do they use ear protection? How often do they swim? These details can really paint a picture of their overall ear health.
It's amazing how much you can learn about someone just by talking to them. But the physical exam is still crucial, right?
Absolutely. Now it's time to put on our detective hats and take a closer look.
Okay, so what are we checking first?
We start with the external ear. We're going to inspect and palpate the auricle, the tragus, and the lobule. Those are the different parts that make up the outer ear.
So we're looking for anything that looks out of the ordinary.
Exactly. We're checking for unusual size, shape, position, any lesions, discoloration, discharge. And when we palpate, we're feeling for any tenderness. Normally, those outer ear structures shouldn't be tender at all.
Got it. So then we move on to the internal ear, which is where the otoscope comes in.
Right. This is where things get interesting using the otoscope. We can peek inside the ear canal. A little bit of earwax is normal, but we don't want to see any signs of infection or blockage.
And then we get to see the eardrum. I remember the first time I saw an eardrum through an otoscope. It was pretty amazing.
That's like a little window into the middle ear. We'll be looking at its color, shape, and consistency. A healthy eardrum should be pearly gray and slightly concave.
Okay, I'm seeing how much you can tell just by looking, but how do you actually test their hearing?
There are a couple of simple but really effective tests we use. First up is the Weber test.
Okay, tell me about that one.
So if a patient says they're having trouble hearing in one ear, we can use the Weber test to see if the problem is in one ear or both. We strike a tuning fork and place it on the center of their forehead.
So they're feeling the vibrations through their skull.
Exactly. And then we ask them if they hear the sound better in one ear or the same in both.
So if they hear it louder in one ear, that means there's a problem with the other ear, the one where the sound seems quieter.
Exactly. Now the RIN test is a little different. This one helps us figure out if the hearing loss is conductive or sensorineural.
Hold on, break that down for me. What's the difference between those two types?
Good question. Conductive hearing loss means there's something blocking sound waves from getting to the inner ear. It could be earwax buildup fluid or even a problem with the tiny bones in the middle ear. Sensorineural hearing loss, on the other hand, means there's damage to the inner ear or the nerve pathways that carry sound to the brain.
Okay, so the RIN test helps you pinpoint where the problem is. How does it work?
For the RIN test, we use the tuning fork again. We strike it and place the base of it on the mastoid process, that's the bony bump behind the ear.
So they're feeling the vibrations through the bone.
Right. We ask them to tell us when they can no longer hear the sound. Then we quickly move the vibrating prongs of the tuning fork in front of the ear canal in a healthy ear. They should be able to hear the sound again through the air.
So if they can hear it longer through the air, that means their air conduction is better than their bone conduction, which is a good sign.
You got it. These tests give us valuable information about the type and potential causes of hearing loss, which helps us tailor our care.
This is fascinating stuff. It makes you realize how important a simple hearing test can be.
Absolutely. And you know what? While we're on the topic of the ear imbalance, there's another quick assessment we can do, the Romberg test.
I've heard of that one, but I'm not sure I could explain it.
It's actually very simple. We ask the patient to stand with their feet together, arms at their sides, first with their eyes open and then closed. We're watching for any swaying or loss of balance.
So if they start to wobble when their eyes are closed, that can mean there's a problem with their inner ear affecting their balance.
Exactly. It's a quick way to check for those inner ear issues that might not be obvious from the hearing tests alone. And remember, problems with balance can be a safety issue, especially for older patients.
Wow. You've given us so much to think about when it comes to the ears.
Yeah.
I'm ready to move on to the next stop on our head-to-toe journey. How about you?
Let's do it. Up next, the mouth, throat, nose, and sinuses. These structures all work together, and they can tell us a lot about a patient's overall health.
I'm all ears. Or maybe I should say I'm all mouth and nose.
All right, let's start with the history for the mouth. We're interested in any sores or lesions, pain, bleeding gums, toothaches, missing teeth, the whole dental health picture.
And I imagine you'd ask about any changes in their sense of taste too, right?
Absolutely. Taste is closely linked to smell, so any changes in either sense could be significant. Speaking of smell, when we ask about the nose one, we're interested in pain, nosebleeds, drainage, stuffiness, allergies. Any changes in their sense of smell, anything that might be affecting their breathing or comfort.
It's amazing how much we take our senses for granted until something goes wrong.
You're so right. And then for the throat, we're focusing on questions about difficulty swallowing, sore throats, hoarseness, things that might impact their ability to speak or eat.
So just like with the ears, we're looking for anything that's interfering with their daily life.
Exactly. And as always, we want to know about their past medical history. Have they had any surgeries in these areas? Any history of sinus infections? Family history of cancer in the mouth, throat, nose, or sinuses?
Those details can help us identify any potential risks or underlying conditions.
Right. And then, of course, we need to talk about lifestyle.
Here's where it gets really interesting, connecting those dots between their habits and their health.
Love that. Okay, so we'll ask about smoking alcohol, use teeth grinding, even diet.
I can see how diet would be especially important for patients with braces or dentures.
You're on fire. And let's not forget about sun exposure, especially for the lips.
Okay. I think I'm starting to see the bigger picture here. You gather all this information from the patient's history, and then you use the physical exam to confirm or rule out any suspicions you might have.
Exactly. So let's talk about the physical exams, starting with the mouth. We begin with a visual inspection, looking at the lips, checking their color and consistency. Are they pale, pink, dry, cracked? These details can be surprisingly informative.
And then we move on to the teeth and gums, right?
You got it. We check the number of teeth, the color, condition, and alignment. Do they have any cavities? Missing teeth. Signs of gum disease?
Right. We're looking for anything that could be causing them pain or affecting their ability to eat.
Then we move on to the buccal mucosa, which is the lining of the cheeks. We use a pen light and tongue depressor to get a good look, checking the color consistency and looking for any abnormalities.
And then the tongue. I remember learning all the different things you can tell from looking at someone's tongue.
It's pretty amazing, right? We ask them to stick out their tongue, and we're observing the color, moisture, size, texture is smooth, rough. Are there any tremors? Does it deviate to one side?
And don't forget to palpate the tongue, too.
Absolutely. We're feeling for any hardening or lumps, especially if we see any lesions. And while we're at it, we'll also ask the patient to touch their tongue to the roof of their mouth so we can see the underside.
Wow, we're really getting a thorough look.
We want to leave no stone unturned. And speaking of leaving no stone unturned, we'll also test the patient's tongue strength and their sense of taste.
How do you test tongue strength? Do they have to do tongue push-ups?
Not quite, but it's a good image. We simply have them press their tongue against the inside of their cheek while we apply resistance with our fingers on the outside. It gives us a good idea of their tongue's muscle strength.
Makes sense. And for taste, I imagine you use those little swabs with different flavors.
You got it. We can place drops of sugar and salt water on different areas of their tongue and see if they can identify the tastes correctly.
Okay, so what's next? The palate.
You're reading my mind. We'll ask the patient to open their mouth wide so we can inspect the hard and soft palates, those structures that make up the roof of the mouth. We're checking their color, making sure there are no growths or abnormalities, and noting any unusual odors.
Because bad breath can sometimes be a sign of something more serious going on.
Exactly. And then we'll check the uvula, that little teardrop-shaped thing that hangs down at the back of the throat.
Ah, yes. The classic say-ah test.
That's the one. We're checking to see if the uvula rises symmetrically when they say, This tells us about the function of the vagus nerve.
Okay, so what else are we looking for back there?
We'll check the tonsils, their size, color, and whether there's any pus or swelling. We'll also examine the back of the throat, looking for any redness, discharge, or lesions.
Okay, I'm getting the hang of this. We're systematically looking for anything that looks abnormal or out of place.
You've got it. Now, how about we shift our focus to the nose?
Sounds good to me. I'm curious to see how we assess that.
Well, we start with the external nose, just like with the ears. We're inspecting and palpating, checking for any unusual color, shape, tenderness, or swelling. And we'll also check if they can breathe easily through both nostrils.
So we're making sure nothing is blocking their airflow.
Exactly. Then we'll grab our trusty otoscope again this time with a special wide tip attachment and carefully inspect the inside of the nose.
I never realized you could use the otoscope for both the ears and the nose.
It's a versatile little tool. We'll be cautious not to touch the nasal septum, which is the delicate wall that divides the nostrils. And finally, we'll move on to the sinuses.
Okay, now this is something I've always been curious about. How can you tell if someone's sinuses are healthy or not?
We use a combination of techniques: palpation, percussion, and transillumination. For palpation, we use our thumbs to gently press on the areas above the eyebrows and below the cheekbones.
So we're checking for tenderness in those areas.
Exactly. If they wince or say it hurts when you press, that could indicate sinus inflammation or infection.
Makes sense. What about percussion?
Percussion involves lightly tapping over those same areas. Again, we're listening for any signs of tenderness or a dull sound, which might indicate fluid buildup in the sinuses.
And transillumination. That sounds fancy.
It's a cool technique. We shine a light against the sinuses, and if they're healthy and air-filled, the light will shine through. If they're filled with fluid, the light won't penetrate as easily.
Wow, it's like you're a detective shining a light on the hidden clues inside the body.
I like that analogy.
Well, we've covered a lot of ground already with the ears, mouth, throat, nose, and sinuses. Should we take a break before tackling the next area?
You know, I think we've got enough momentum to keep going. What do you say we jump right into the thorax and lungs?
I'm game if you are.
Let's do it. Now, when we're talking about the thorax and lungs, we're not just listening to breath sounds, we're piecing together a puzzle, gathering clues from their history, their symptoms, their lifestyle, all of it.
Okay, I'm intrigued. Let's start with the history. What kind of questions are we asking about their breathing?
First and foremost, we need to know if they're experiencing any difficulty breathing or dyspnea. We want to know how they would describe it, what triggers it, and if it comes with any other symptoms.
So are they short of breath all the time? Only when they exert themselves do they wake up gasping for air at night?
Exactly. We want to know the details. And speaking of nighttime, it's important to ask about snoring and any pauses in breathing while they sleep.
Sleep apnea. My dad has that, and he says it's really disruptive to his sleep.
It can be a serious condition. And then, of course, we need to ask about chest pain.
Chest pain is always a red flag, right?
It can be. We want to get a detailed description. Where is the pain? What does it feel like? Does it radiate anywhere? What makes it better or worse? Is it related to breathing or activity?
Right. We're trying to figure out if it's related to their heart, their lungs, or something else entirely.
You're getting it. And don't forget to ask about coughing. When does it happen? How often? Is it dry? Or do they produce phlegm? What does the phlegm look like?
I can see how those details could be really helpful in figuring out what's going on.
They can be. And here's something that might surprise you. We also need to ask about gastrointestinal symptoms. Things like heartburn, frequent hiccups, or a chronic cough can sometimes be related to GI issues rather than purely respiratory ones.
Wait, really? I would never have thought to ask about those things in a respiratory assessment.
It's all about making those connections. Remember, the body is a complex system and everything is interconnected. Now, before we move on to the physical exam, let's talk about their past health history.
So we'd ask about any previous respiratory problems, surgeries, allergies, testing any recent travel that might have exposed them to different illnesses, that sort of thing.
You're a pro at this.
Yeah.
And don't forget about family history. Is there a history of lung disease in their family? Did anyone in their household smoke when they were growing up?
Right. All those little clues help us piece together the bigger picture. And then, of course, we come to lifestyle and health practices. This is where we really start to understand their individual risk factors.
Smoking is a big one, right?
Absolutely. We need a detailed smoking history, including past and present smoking habits, how much they smoke or smoked, what triggers their smoking, and any attempts to quit.
And even if they don't smoke, we need to ask about secondhand smoke exposure.
Right. We also want to know about their environment, especially their work environment. Are they exposed to dust fumes or other irritants?
And what about stress?
Yeah.
I know stress can manifest in so many ways, including respiratory issues.
Absolutely. We'll ask about their stress levels, how it affects their breathing, and what coping mechanisms they use. And of course, we need to know about any medications they're taking, both prescription and over-the-counter, as well as any home treatments or herbal remedies they use for respiratory problems.
This is amazing. I'm starting to feel like a real detective gathering all these clues. But now it's time for the physical exam, Ryden. Where do we start?
We'll start with the posterior thorax exam. We'll ask the patient to sit up straight so we can get a good look at their back.
Okay, first up, inspection. What are we looking for?
We're checking for any signs of respiratory distress, like nasal flaring or pursed lip breathing. We'll also observe the color of their face lips and chest, looking for any bluish tinge that might indicate low oxygen levels.
And their nails, right?
Yes. We'll check their nail color and shape. Clubbing where the fingertips enlarge and the nails curve downward can be a sign of chronic lung problems.
Wow, I never knew that.
There's always something new to learn. We'll also pay attention to the shape and configuration of their chest wall. Are the shoulders level? Are they using their neck or shoulder muscles to help them breathe?
So we're looking for any asymmetry or signs that they're struggling to breathe.
Exactly. Now let's move on to palpation. We're going to feel for any tenderness or unusual sensations. We'll also check for crepitus.
Crepitus, is that like a crackling sensation?
You got it. It feels like bubble wrap under the skin, and it can be a sign of air trapped in the tissues, which can happen with certain lung conditions. We'll also palpate any lesions we saw during the inspection and check for fremitus.
Hold on. Remind me what fremitus is again.
Fremitus is the vibration you can feel on the chest wall when the patient speaks. It's a subtle vibration, but it can tell us if sound is transmitting properly through the lungs.
So we're basically feeling for the sound waves.
Exactly. We'll also assess chest expansion, placing our hands on their back and watching how their chest moves when they breathe in. We're making sure both sides are expanding equally.
Okay, I'm following along. What's next? Percussion?
You got it. We'll use our fingers to tap on the chest wall like tiny little drumsticks.
I love that image.
Different sounds can tell us about the density of the tissues underneath. A resonant sound means the lungs are filled with air, which is what we want to hear. A dull sound could indicate fluid or a solid mass.
So we're comparing the sounds on both sides of the chest.
Exactly. We'll also use percussion to figure out how much the diaphragm is moving when they breathe.
How do you do that?
We basically percuss down the back until we hear the sound change from resonant to dull, which tells us where the diaphragm is sitting. We have them take a deep breath and percuss again, measuring the distance between those 2 points. That's the diaphragm's range of motion.
Wow, that's pretty clever.
Right. And finally, we come to the part everyone loves, auscultation. We'll listen to the breath sounds using our trusty stethoscope.
Okay, time to hear those lungs in action.
Exactly. We'll listen with the diaphragm of the stethoscope covering all the different areas on the back.
I'm assuming there are different types of breath sounds.
There are. Normal breath sounds are soft and rustling like wind through the trees. But we're also listening for any abnormal sounds like crackles, wheezes, or raunchy.
Those don't sound so good.
They can be signs of things like fluid in the lungs, airway narrowing, or mucus buildup. And finally, we'll do a voice sounds assessment, having the patient say certain words or phrases while we listen to their chest.
So we're listening for how the sound changes as it travels through their lungs.
Exactly. It can help us pinpoint the location of any problems we might be hearing.
So we've covered inspection, palpation, percussion, and auscultation of the posterior thorax. What about the front of the chest?
We do the same thing on the anterior thorax, basically repeating the process on the front of the chest.
Okay, so we'll be looking at the shape and symmetry of the chest, the position of the sternum and ribs, and listening for any abnormal breath sounds.
You got it. And don't forget to check for retractions. Those are inward movements of the chest wall between the ribs or below the breastbone, which can be a sign that they're really working hard to breathe.
Okay, that makes sense. So it's basically the same process, just from a different angle.
You're getting the hang of this.
We'll have a great teacher. So we've covered the respiratory assessment. What's next on our head-to-toe adventure?
Let's move on to the breasts and lymphatic system. Now, this part of the exam can feel a little sensitive, so it's important to explain everything to your patient clearly and make them feel comfortable.
Absolutely. And for this episode, we'll be focusing specifically on the examination of non-pregnant women's breasts.
Right. And I want to emphasize right off the bat that any report of lumps or swelling needs to be investigated thoroughly.
Right. Those can be early signs of breast cancer, so it's important to take them seriously.
Absolutely. So when we're taking the history, we want to ask very specific questions about any lumps or swelling. Where are they located? When did they first notice them? Have they changed in size or shape? Are they related to their menstrual cycle?
And I imagine you'd also ask about any associated skin changes, right? Like redness, warmth, dimpling, or rashes.
Exactly. We're looking for anything that might be out of the ordinary. We'll also ask about any changes in breast size or firmness, and any pain. Does it hurt to touch? Does the pain come and go?
Right, because pain can be a sign of a lot of different things, so it's helpful to know the details.
Exactly. And we can't forget about nipple discharge. What color is it? What's the consistency? Does it have an odor? When does it happen? Which nipple is affected?
So we're really trying to get a complete picture of their breast health, both past and present.
You got it. We'll also ask about their past medical history. Have they ever had any breast disease or surgeries? When did they start menstruating? Have they gone through menopause? Have they had any children?
And family history is crucial here too, right?
Absolutely. We need to know if there's any history of breast cancer in their family. Who was affected? What was their relationship to the patient?
Right, that can give us valuable insights into their risk factors. And then, of course, we'll talk about lifestyle and health practices.
Right, we'll ask about any medications they're taking, especially hormones, contraceptives, or antipsychotics, as well as any environmental exposures to radiation, benzene, or asbestos.
And we'll also ask about their diet and alcohol consumption, exercise habits, and the type of bra they wear during exercise.
You're on a roll. We also want to know about their feelings about their breasts and any fears related to breast disease, their self-examination practices, and any changes they've noticed during self-exams.
And we'll ask about the timing of their last clinical breast exam and mammogram.
Exactly. Now, for the physical exam, we'll be doing two things: inspection and palpation.
Okay, so what are we looking for during inspection?
We'll have the patient disrobe from the waist up and sit comfortably with her arms at her sides. We'll explain what we're doing and what we're looking for to put her at ease. First, we'll observe the size and symmetry of her breasts. Are they roughly the same size? Is one noticeably larger or smaller than the other?
So if one breast is significantly different, that could be a cause for concern.
Right. We'll also look at the color and texture of the skin, looking for any unusual lesions, redness, or other abnormalities.
What about the veins?
Good question. The veins should be barely visible or symmetrical. If they're unusually prominent or asymmetrical, that could be a sign of a problem.
What about the areolas?
We'll check the areolas too, their color, size, shape, and texture. And then, of course, we'll inspect the nipples themselves.
So we're looking for any dryness, lesions, bleeding, or discharge?
You got it. Now, to check for retraction and dimpling, we'll have her raise her arms overhead, then press her hands against her hips, and finally press her hands together in front of her.
Hold on, why do we have her do all that?
These movements help to tighten the chest muscles, which can make any retraction or dimpling more obvious. Retraction is when the nipple or the skin around the nipple pulls inward. Dimpling is when the skin of the breast looks puckered or indented. Both of these can be signs of breast cancer.
Okay, that makes sense. So we're looking for any subtle changes that might not be visible when she's just sitting relaxed.
Exactly. Now, after we've thoroughly inspected her breasts, it's time for palpation.
Okay, so what are we feeling for?
We'll start by gently palpating the entire breast tissue, feeling for any lumps or masses.
And we'll check the texture and elasticity of the tissue, right?
Healthy breast tissue should feel firm and elastic. We'll also note any tenderness and temperature changes.
So if it feels lumpy, hard, or unusually warm, that could be a red flag.
Exactly. We also want to pay close attention to any masses we might find. We'll note their location, size, shape, how easily they move, how firm they feel, whether they're tender, and what the skin over the mass looks like.
That's a lot of details to keep track of.
It is, but it's important to be thorough. We'll also gently squeeze the nipple to check for any discharge. And if the patient has had a mastectomy or lumpectomy, we'll examine the scar and any remaining tissue for any abnormalities.
Just sort of making sure we're covering all the bases.
Exactly. Now, before we move on to the next area, we'll also take a quick look at the axillae, or underarms.
So we're checking the lymph nodes.
Right. We'll inspect the skin for any rashes or infections, and then gently feel for any enlarged or tender lymph nodes.
Okay, I'm seeing how all these assessments are connected. The lymphatic system plays a big role in immunity, so any problems there could be a sign of something else going on.
You're absolutely right.
Well, I feel like we've covered a lot of ground already. Should we stop here for part 1?
I think that's a good stopping point. We've covered some important areas: ears, mouth, throat, nose, sinuses, thorax and lungs, and the breasts and lymphatic system.
Wow, it's amazing how much information we can gather during just one head-to-toe assessment.
It's true, but we're not done yet. Be sure to join us for part 2, where we'll continue our journey through the body, exploring the heart and neck vessels, the peripheral vascular system, and the abdomen.
We'll see you then.
Welcome back to Student Nurses Station.
We're picking up right where we left off with our head-to-toe assessment deep dive. Last time we covered a lot of ground, from peeking inside ears to checking for swollen lymph nodes.
It's like putting together a giant jigsaw puzzle, gathering clues from every system in the body.
Exactly. And in this episode, we're focusing on the cardiovascular system.
That's right. We're going to talk about how to assess the heart and neck vessels and how those findings can help us understand what's going on with our patient.
Okay, so let's start with the history. What are some key things to ask about?
Well, chest pain is a big one. Anytime a patient mentions chest pain, our ears perk up. We need to get a really thorough history, asking about the type of pain, the location, if it spreads anywhere, how long it lasts, how often it occurs, how severe it is, all the details.
Right, and we always want to ask them to rate the pain on a scale of 0 to 10. That helps us get a sense of just how much it's bothering them.
Absolutely. We also want to know if anything makes the pain worse, like exertion, and if it's accompanied by other symptoms like sweating.
Those details can help us figure out if the pain is related to the heart or something else.
Exactly. And we also need to ask about palpitations, those feelings of a racing or fluttering heartbeat.
Palpitations can be really scary for patients. I imagine they can feel like their heart is going to jump out of their chest.
They can be very unsettling, so it's important to ask about them and try to figure out what's triggering them.
Okay, so we've talked about chest pain and palpitations.
Yeah.
What other symptoms should we ask about?
Well, fatigue is another important one. Has the patient noticed any unusual tiredness? When did it start? Is it constant or does it come and go? Is it worse at any particular time of day?
Fatigue can be a symptom of so many different things, so I can see why you'd want to get a good history.
It's true. And then there are other symptoms that might seem unrelated to the heart, but can actually be important clues. Things like shortness of breath, waking up at night to urinate, dizziness, swelling in the legs or feet, and even heartburn.
Wait, heartburn? Really?
I know it sounds strange, but frequent or persistent heartburn, especially in older adults, can sometimes be a sign of a heart problem.
Wow, I never knew that. It really shows how interconnected all the systems in the body are.
It does. Now let's talk about the past health history. We need to know about any previous heart problems like murmurs, rheumatic fever, or heart defects.
And we'll ask about any procedures they've had, like cardiac catheterization or bypass surgery.
Right. And we'll want to know about any previous EKGs and the results, as well as their cholesterol levels from their last lipid panel.
We also want to know about any medications they're taking for heart disease and whether they monitor their own heart rate or blood pressure.
Absolutely. And of course, we can't forget about family history.
Family history is so crucial in understanding a patient's risk for heart disease.
Exactly. We need a detailed family history of any heart attacks, high blood pressure, coronary artery disease, high cholesterol, and diabetes.
Those conditions can have a strong genetic component, so it's vital information to have.
Absolutely. And then we'll ask about their lifestyle. This is where we really get into the nitty-gritty of their habits and how they might be affecting their heart health.
Smoking is a huge risk factor, so we'll definitely want to know about their smoking history.
Right, and we'll want to know about their stress levels, how they cope with stress, their diet, how much alcohol they drink, and how much exercise they get.
Those lifestyle factors can have a big impact on heart health.
They can. Now, here's a question I like to ask. How has your heart health affected your daily life?
That's a great question. It gets to the heart of how these symptoms are actually impacting the patient's quality of life.
Exactly. So we'll ask about any changes in their activity levels over time, any limitations they're experiencing because of their symptoms, and whether they're able to care for themselves independently. We'll also ask about their sleep. Do they have trouble sleeping? Do they wake up during the night? Do they feel rested in the morning?
Those can all be clues to underlying heart problems, right?
They can. And finally, we want to explore their feelings and fears about their heart health. Do they feel anxious about their heart? Are they afraid of having a heart attack?
It's important to address those concerns and provide reassurance when possible.
Absolutely. Okay, now that we've covered the history, let's move on to the physical exam. Are you ready to put your stethoscope skills to the test?
I'm ready. I've been practicing my lub-dubs.
Excellent. Let's start with the neck vessels first. We'll inspect the jugular venous pulse.
So we're looking at the veins in the neck, right?
Exactly. We'll position the patient lying down with their head elevated at about a 45-degree angle. Then we'll use a pen light to shine a light across their neck, which helps us see those jugular veins better.
What are we looking for in those veins?
We're looking for distension, which means the veins are bulging or prominent. This can be a sign of right-sided heart failure, meaning the right side of the heart isn't pumping blood effectively.
So if the veins are bulging, that's a red flag.
Right. Now, after inspecting the jugular veins, we'll move on to the carotid arteries.
Those are the big arteries in the neck that supply blood to the brain, right?
You got it. We'll start by listening to them with the bell of our stethoscope. We'll ask the patient to hold their breath for a moment while we listen for any bruits.
What are bruits? I've heard that term before, but I'm not sure I could explain it.
A bruit is a whooshing sound that we hear through the stethoscope. It can indicate turbulent blood flow, which might mean there's a narrowing or blockage in the artery.
So it's like the sound of a river rushing through a narrow channel.
That's a great analogy. After we listen to the carotid arteries, we'll gently feel them with our fingers, checking for any unusual pulsations or vibrations.
We'll want to be careful not to press too hard on those, right?
Absolutely. Pressing too hard on the carotid arteries can stimulate the vagus nerve, which can cause a drop in heart rate and blood pressure.
Okay, I'll be gentle. So we've checked the neck vessels. Now it's time for the main event, the heart.
Let's get to the heart of the matter. We'll begin by inspecting the chest, looking for any visible pulsations.
We'll position the patient lying down again with their head elevated right.
Exactly. We'll stand on the patient's right side and look for the apical impulse, which is where we can see the heart beating against the chest wall.
It's usually located in the 5th intercostal space at the midclavicular line, right?
You're remembering your landmarks. We'll also be looking for any other unusual pulsations that might indicate a problem with the heart's rhythm or structure.
Okay, after inspection, we move on to palpation.
Right. We'll use the palm of our hand to feel for the apical impulse we're feeling, for that gentle tap as the heart beats against the chest wall.
And we'll note the location, size, and strength of the impulse.
Exactly. We'll also feel for any thrills.
Thrills, like chills, but for the heart.
Kind of. A thrill is a vibration you can feel with your hand, like a cat purring. It can indicate turbulent blood flow within the heart.
So if we feel a thrill, it could mean there's a problem with a valve or another structure in the heart.
Right. Now, are you ready for the grand finale, auscultation time?
Let's hear that symphony of the heart.
We'll use both the diaphragm and the bell of our stethoscope to listen to the heart sounds.
I remember learning that the diaphragm is best for hearing high-pitched sounds and the bell is better for low-pitched sounds.
That's right. We'll start by listening at the apex. That's where we felt the apical impulse using the diaphragm to assess the heart rate and rhythm.
So we're counting the beats per minute and making sure the rhythm is regular.
Exactly. And if we detect an irregular rhythm, we'll also check for a pulse deficit.
A pulse deficit. How do we check for that?
We'll feel for the patient's radial pulse at their wrist while simultaneously listening to their heart with the stethoscope.
And if we feel fewer pulses at the wrist than we hear heartbeats with the stethoscope, that means there's a pulse deficit.
Exactly. A pulse deficit means that some of the heartbeats aren't strong enough to generate a palpable pulse wave.
So it's a sign that the heart might not be pumping efficiently.
Exactly. Now, after checking the rate and rhythm, we'll listen for the heart sounds themselves, starting with S1 and S2.
Those are the classic lub-dub sounds, right?
That's right. S1, the lub, is the sound of the mitral and tricuspid valves closing.
And S2, the dub, is the sound of the aortic and pulmonic valves closing.
You've got it. We'll listen for the intensity of those sounds and also for any splitting.
What do you mean by splitting?
Sometimes you might hear the lub or the dub sound as two distinct sounds very close together. A little bit of splitting can be normal, but sometimes it can indicate a problem with how the valves are working.
Okay, so we're listening for those subtle differences in the sounds.
Exactly. We'll also listen for any extra heart sounds like S3 and S4.
I remember learning that those extra sounds are called gallops, and they can be signs of heart failure.
That's right. We'll listen carefully for any gallops and also for murmurs.
Murmurs are those whooshing or swishing sounds, right?
Exactly. Murmurs can happen when blood flow through the heart is turbulent.
So it's like those brutes we listen for in the carotid arteries, but this time in the heart itself.
You're making the connections. We'll use both the diaphragm and the bell to listen for murmurs, and we'll note their timing, their intensity, and their location.
And sometimes you might have the patient change positions to hear the murmurs better, right?
Absolutely. Some murmurs are easier to hear when the patient is lying on their side or sitting up and leaning forward.
Okay, so we've covered a lot of ground with the heart. What's next?
Now let's move on to the peripheral vascular system. This is all about assessing the circulation in the arms and legs.
So we're making sure blood is flowing properly to the extremities.
Exactly. We'll be looking for any signs of poor circulation, such as swelling, discoloration, pain, or changes in temperature.
Okay, let's start with the history. What are some key things to ask about?
We'll ask about any pain, numbness, or tingling in the arms or legs, which could be signs of peripheral neuropathy.
Peripheral neuropathy is damage to the nerves in the extremities, right?
Exactly. We'll also ask about any coldness, paleness, or hair loss in the extremities, which can be signs of poor circulation.
And swelling in the arms or legs, especially if it's only on one side.
Right. Unilateral swelling on just one side can be a sign of a deep vein thrombosis or DVT.
A DVT is a blood clot in a deep vein, usually in the legs.
You got it. And we'll ask about any leg pain or cramps, especially if they happen during activity, which could be a sign of intermittent claudication.
Intermittent claudication is pain in the legs caused by poor blood flow to the muscles, right?
Exactly. And we'll ask about any sores or wounds on the legs that are slow to heal, which can also indicate poor circulation.
Okay, so we've covered the symptoms. What about the past health history?
We'll ask about any previous problems with their circulation, such as peripheral vascular disease or PVD or DVT, and we'll ask about any surgeries or procedures involving the blood vessels.
And any medical conditions that can affect circulation, like diabetes, high blood pressure, or high cholesterol.
Right. We also need to know about any medications they're taking that could affect circulation, like blood thinners.
And we'll ask about family history of any circulatory problems.
You've got it. And as always, we'll talk about lifestyle.
So we'll ask about smoking diet and exercise habits.
Exactly. And we'll ask about their job and any activities that require them to stand or sit for long periods, which can increase the risk of circulatory problems.
And we'll ask about any recent travel, especially long flights or car rides, which can increase the risk of DVT.
Okay, now that we've covered the history, let's move on to the physical exam.
Time to put on our detective hats and search for clues.
We'll start by inspecting the arms and legs, looking for any signs of poor circulation. Are the extremities a normal color? Do they look pale or bluish? Are there any sores or ulcers? Do they have a normal amount of hair?
Right. And we'll compare the temperature of the extremities feeling for any differences between the two sides.
If one side feels colder than the other, that could indicate poor circulation on that side.
And then we'll palpate the pulses in the arms and legs.
We'll check for the rate, rhythm, and strength of the pulses. A weak or absent pulse can indicate poor circulation.
And what about capillary refill?
We'll check that too. We'll press down on a fingernail or toenail for a few seconds, then release the pressure and see how long it takes for the color to return.
It should turn white when we press down, then back to pink within a couple of seconds.
Exactly. If it takes longer than that, it could indicate that blood flow to the extremities is sluggish.
Okay, so we've inspected the arms and legs,
Yeah.
checked the pulses and capillary refill time. What's next?
Next, we'll assess for edema, which is swelling caused by fluid buildup in the tissues.
How do we check for edema?
We'll press gently on the skin over a bony area like the shin or ankle for a few seconds. If there's edema, the skin will indent and stay indented for a bit after we release the pressure.
We'll grade the edema on a scale, depending on how deep the indentation is.
Right. Now, are you ready to move on to the next stop on our journey, the abdomen?
Lead the way.
The abdomen is fascinating because it houses so many vital organs. Just like with the other systems, we'll start by taking a thorough history.
So what kinds of questions are we asking about the abdomen?
We'll start with any abdominal pain. Of course, we want to know where the pain is, what it feels like, how severe it is, how long it's been going on, and if it's accompanied by any other symptoms like nausea, vomiting, or diarrhea.
Abdominal pain can be caused by so many different things, so those details are really important.
They are. We'll also ask about any changes in appetite, weight loss, or gain in bowel habits.
Those changes can be signs of all sorts of digestive problems.
You're right. We also want to know about any history of gastrointestinal disorders like ulcers, irritable bowel syndrome, or inflammatory bowel disease.
And any surgeries or procedures involving the abdomen?
Right. And as always, we'll ask about family history of any gastrointestinal disorders.
Okay, so now it's time for the physical exam.
Right. Are you ready to put your inspection, auscultation, palpation, and percussion skills to the test?
I think I'm ready. But remind me again, what's the correct order for those?
Good question. For the abdomen, we actually auscultate before we palpate.
Why is that?
Because palpation can stimulate bowel sounds, which could give us a false impression of what's going on. So we listen first and then we feel.
Okay, that makes sense. So what are we looking for during inspection?
We'll start by looking at the shape and contour of the abdomen. Is it symmetrical? Are there any bulges or distension?
We'll also be looking for any scars, stretch marks, or visible pulsations.
Right. Now, once we've inspected the abdomen, we'll grab our stethoscope and listen for bowel sounds.
You'll listen in all 4 quadrants of the abdomen, right?
Exactly. We're listening for those gurgling and clicking sounds that indicate the intestines are doing their job.
And we'll also listen for any bruits over the major arteries in the abdomen.
Right. Just like with the carotid arteries, bruits in the abdomen can indicate narrowing or blockage of the blood vessels.
Okay, so we've inspected and auscultated, now we can finally palpate.
That's right. We'll start by gently feeling all 4 quadrants of the abdomen, checking for any tenderness guarding rigidity or masses.
Guarding and rigidity, those are signs of peritoneal irritation, right?
That's got it. Peritoneal irritation can be a sign of a serious problem like appendicitis or a perforated ulcer.
So those are red flags we definitely don't want to miss.
Absolutely. We'll also try to feel the liver, spleen, and kidneys. Usually we can't feel these organs unless they're enlarged.
And finally, we'll percuss the abdomen.
Percussion helps us determine the size and density of the organs.
So a tympanic sound, which is like a drum, indicates that the area is filled with gas, which is normal for the intestines.
Right. And a dull sound indicates that the area is filled with fluid or a solid mass.
Okay, so we've inspected, auscultated, palpated, and percussed the abdomen. What's next on our head-to-toe checklist?
I think we've covered enough ground for one episode. We've tackled the peripheral vascular system and the abdomen. That's a lot of anatomy and physiology.
It's amazing how much we can learn about a patient just by listening to their story and carefully examining their body.
It's true. And remember, the head-to-toe assessment is just one piece of the puzzle.
Right. We also need to consider the patient's medical history, their lab results, their vital signs, and all the other information we've gathered to form a complete picture of their health.
Absolutely. Be sure to join us for part 3 of our head-to-toe assessment series, where we'll explore the musculoskeletal system, the neurological system, and wrap up our journey through the body.
We'll see you then. Welcome back to Student Nurses Station.
We're wrapping up our head-to-toe assessment deep dive. With part 3, you've been with us through heart murmurs, palpating abdomens, the whole works.
It's been quite a journey. And today we're focusing on the musculoskeletal and neurological systems. 2 systems that are super important for how our patients move and function in the world.
Exactly. These assessments can give us a ton of insight into a patient's mobility, their coordination strength, and even their mental status.
Okay, I'm ready to dive in. Let's start with the musculoskeletal system. What kind of questions are we asking during the history?
Well, just like with the other systems, we start by asking about pain, any pain, stiffness, or swelling in their joints.
That could be a sign of arthritis, right?
It could be. Or it could be something else entirely. That's why we ask follow-up questions. When did the pain start? What makes it better or worse? Which joints are affected?
Right. We're trying to get a clear picture of what they're experiencing.
Exactly. We also want to know about any limitations in their range of motion. Can they bend over easily, reach for things, grip objects?
Those limitations can really impact their ability to perform daily activities.
Absolutely. And then we ask about muscle weakness, fatigue, or tremors.
Those can be signs of a lot of different things, right? from neurological issues to medication side effects.
You're right. And we always ask about any history of injuries, fractures, sprains, strains, anything that might be affecting their current musculoskeletal health.
So we're gathering all these clues from their history, and then we move on to the physical exam to see what we can find.
Exactly. We start by observing their posture and gait. How do they stand? How do they walk? Are they using any assistive devices like a cane or a walker?
So we're looking for any signs of pain, stiffness, or instability.
Right. Then we'll assess their range of motion in all the major joints: neck, shoulders, elbows, wrists, fingers, hips, knees, ankles, toes, the whole 9 yards.
We'll be looking for any limitations or pain during those movements.
Exactly. And we'll palpate those joints, muscles, and bones, feeling for any tenderness, swelling, or warmth.
Tenderness, swelling, and warmth could be signs of inflammation or injury.
Yeah,
Remember.
got it. And finally, we'll assess their muscle strength.
How do we do that? Do we make them lift weights?
Haha, not quite. We'll have them push and pull against our resistance as we try to move their limbs in different directions.
So it's like a gentle arm wrestling match.
You could say that. It gives us a good idea of how strong their muscles are.
Okay, so we've covered the musculoskeletal system. Now, let's move on to the neurological system. I remember feeling a bit intimidated by this assessment when I was first learning it.
I think a lot of nursing students feel that way, but once you break it down into manageable steps, it's not as scary as it seems.
Okay, good to know. So what are the main components of the neurological assessment?
We're basically checking 4 things: mental status, cranial nerves, reflexes, and motor and sensory function.
Okay, let's break those down one by one. What do we assess for mental status?
We start with their level of consciousness. Are they alert and responsive, or are they drowsy or confused?
So we're getting a sense of how awake and aware they are.
Exactly. Then we check their orientation. Do they know who they are, where they are, what day it is?
It tells us if they're oriented to person, place, and time.
Right. We'll also check their short-term and long-term memory. Can they remember what they had for breakfast? Can they recall events from their childhood?
And we'll listen to their speech, making sure it's clear and fluent.
Exactly. We also want to assess their mood and affect. Are they happy, sad, anxious, irritable?
So we're looking for any signs of mood disorders or emotional distress.
You got it. Now let's move on to the cranial nerves.
There are 12 pairs of cranial nerves, right?
That's right. They control all sorts of important functions, from vision and hearing to smell, taste, facial movements, and swallowing.
So how do we assess all those nerves?
We perform a series of targeted tests, depending on the specific nerve we're checking. For example, to test the optic nerve, which is responsible for vision, we'll check their visual acuity using an eye chart, and we'll test their peripheral vision.
And I remember learning about the test for the oculomotor nerve, where you shine a light in their eyes and watch how their pupils constrict.
That's a good one. And to test the facial nerve, we'll have them make different facial expressions: smile, frown, raise their eyebrows, puff out their cheeks.
It sounds like we're putting their facial muscles through a workout.
It can be a bit silly, but it's important to make sure those nerves are functioning properly.
Okay, so after the cranial nerves, we move on to reflexes.
Reflexes are those involuntary muscle contractions that happen in response to a stimulus. Think about when the doctor taps your knee with a reflex hammer and your leg jerks.
The classic knee-jerk reflex.
Exactly. We'll test a variety of reflexes, including the biceps, triceps, patellar, and Achilles reflexes.
We're checking for the presence and strength of those reflexes, right?
Right. A reflex that's absent or weak can indicate a problem with the nerves or muscles involved, and a reflex that's overly brisk can also be a sign of a neurological problem.
So we're looking for the Goldilocks reflex, not too weak, not too strong, just right.
I like that. And finally, we'll assess their motor and sensory function.
So we're checking how well they can move and how well they can feel things.
Exactly. For motor function, we'll assess their muscle strength again, and we'll also check their coordination and balance. We might ask them to walk heel to toe or touch their finger to their nose.
Those tests can be tricky even for people without neurological problems.
They can be. And for sensory function, we'll test their ability to feel different sensations: light touch, pain, temperature, and vibration.
I remember using a cotton swab and a safety pin for those tests, and a tuning fork to test for vibration.
Exactly. It's amazing how much we can learn about the nervous system just by observing how the patient responds to those simple stimuli.
Cool. I feel like we've covered a ton of information today. We've traveled from head to toe, exploring all the major systems and how to assess them.
We have. It's been quite a deep dive.
It has. And I have to say, I feel a lot more confident about my head to toe assessment skills now.
That's what we like to hear. Remember, practice makes perfect. The more you practice your assessment skills, the more comfortable and confident you'll become.
Absolutely. And don't forget, we have those free downloadable nursing books linked in the description if you want to review any of the information we covered today.
They're a great resource for studying.
Well, thanks for joining us on this head-to-toe adventure. We hope you learned a lot, and we'll see you next time on Student Nurses Station.
See you then.